Good evening, all the trainees who are trying to revise this video in our YouTube channel. In continuation of Urology FRCS exam preparation, today we are discussing intermediate and high risk prostate cancer. We have a trainee. The trainee has already completed the low risk prostate cancer in the last discussion with a wonderful, nice, evidence backed discussion. Today we are going to the next stage. Welcome. We have the scenario now. You have 72-year-old man, fit and well, no medical comorbidities, no family history of prostate cancer, is voiding urinary symptoms were completely absent. He had prostate biopsy for his increased PSA of 9 and PSA finding of small area pyrad 5 and majority area of pyrad 4. The biopsy came as adenocarcinoma Gleason 3 plus 4 involving 4 out of 24 cores. So what are you going to do?
So I will discuss this patient at the Urology MDT to discuss further management options to confirm the histology findings. Looking at his risk stratification according to the NICE guidelines, he has intermediate risk disease as his Gleason score is 7. And I'll therefore be recommending that he be offered radical treatment options in the form of either a radical prostatectomy or radical radiotherapy.
How are you going to discuss these two options?
I'll see the patient on an urgent basis in a prostate results clinic with the urology cancer nurse specialist present. If the local facilities permit, this will also be joint clinic with an oncologist present. I'll explain the findings to the patient that he has a diagnosis of cancer, that it appears to be localized, but it is of an intermediate risk needing radical treatment. And from the urology side, I will use a Bounce consent form and information leaflet to talk through a radical prostatectomy with him, explaining how the procedure is performed with the route dependent upon what is available in local facilities, the benefits in terms of treatment, the risks and alternative treatments. I'll counsel them about generic risks of any procedure, such as bleeding, infection and pain, the anaesthetic risk. I'll also talk about specific complications of the operation, including biochemical recurrence needing additional treatment, urinary incontinence, erectile dysfunction, rectal injury, injury to blood vessels, and the need for possibly additional procedures to be performed.
Do you think this patient will need any further staging?
He has intermediate risk disease, and the PSA is 9. I don't think that he will need a bone scan. The likelihood of a positive bone scan with his PSA between 4 and 10 is less than 5%.
Yeah, it's around 2.3%. 5% is around for PSA between 10 and 19. Any other CT scan do you think he needs for lymph node involvement?
So he doesn't need the CT scan to determine lymph node involvement. The risk of that can be determined by using scores and nomograms. If he were to undergo radical prostatectomy, then he would need to undergo pelvic lymph node involvement, as that is a gold standard for staging, for pelvic lymph node staging prostate cancer.
So what nomogram you will use to identify whether the lymph node staging needed or not?
According to the NICE guidelines, I'll use the Roche formula, which is calculated by taking 6 away from the Gleason score, multiplying that number by 10, and then adding 2/3 of the PSA. So for this man, This calculation, so 2/3 of the PSA is 6. Gleason score is so overall the risk of pelvic lymph node for this man based on the Roche formula is 6. There are other nomograms that can be used, including the Brachytherapy nomogram, which takes into account the PSA, the MRI features of maximum lesion diameter, or the stage of the lesion, the Gleason score of biopsies, and the percentage of biopsy cause involving cancer. And there's also the MSKCC nomogram.
Okay, so let us assume that this patient's risk for lymph node involvement, say, comes around 2 to 3%, and hence we are not doing any further staging like CT scans. He had his MRI, which covered the pelvis, which haven't showed any significant lymph nodes. You are planning for radical prostatectomy. What is the evidence for radical prostatectomy in this group of men?
The main evidence for this comes from 2 trials, the PIVOT trial and the Scandinavian Cancer Prostate Group. The PIVOT trial took place in the USA, compared watchful waiting compared to radical prostatectomy. And this, while this found no overall benefits for cancer-specific and overall survival, it did find a statistically significant benefit in survival for patients with intermediate risk prostate cancer. With the Scandinavian study, this did find a significant improvement in cancer-specific survival for patients undergoing a radical prostatectomy compared to observation alone.
Okay, what do you know about the PROTECT trial?
So PROTECT was published in 2017. This looked at more than 2,500 men with localized prostate cancer who were randomized to either active surveillance, radical prostatectomy, or radical radiotherapy. This found that there was no overall difference in overall survival 10 years between all groups. And this was 99% for the radical treatment arms and 98% for the active surveillance arms. However, 21% of patients in the active surveillance arm developed disease progression compared to 8% in the surgery and radiotherapy arms, and only 3% of patients in the surgery and radiotherapy arms developed metastases compared to 8% in the active surveillance arm. 53% of patients on active surveillance also required radical treatment.
Okay. By what method you're going to perform radical prostatectomy for him?
First of all, I'll perform radical prostatectomy in a tertiary unit that has a high volume of cases. The methods, again, will depend upon local availability and also expertise. In my center, robotic assisted radical prostatectomy is performed, and this has been associated with a significant reduction in hospital stay and blood transfusion, although this has not been shown to have improvement or benefit in terms of oncological outcomes.
Okay. Can you summarize Bouse leaflet for him? What are you going to explain in the Bouse leaflet?
So I will outline how the procedure is performed and the likely hospital stay. I'll explain the benefits of the procedure in curing his cancer. I'll talk about the risks of the procedure, including bleeding, needed transfusion, or further procedures such as drainage or further operation, risk of infection, sepsis, pain, the anesthetic risk, DVT and PE. I'll explain specific risks, including bladder neck stenosis needing further procedures, Peyronie's disease, biochemical recurrence needing additional treatment, rectal injury, possibly needing a colostomy, incontinence, and erectile dysfunction requiring additional treatments.
How will you counsel and help this patient to prevent erectile dysfunction and urinary incontinence post-op?
With regards to, I'll talk to the patient about the findings of the PROTECT trial in terms of the findings for each of those side effects, complications, explaining that at 6 years, it was found that of men undergoing radical prostatectomy, 69% had urinary incontinence. And for erectile dysfunction, this figure was approximately 50%. With regards to urinary incontinence, I will measure the membranous urethral length on MRI scan, on the preceding MRI scan, as a length of greater than 12 millimeters is associated with the greater improvement in incontinence. And I will also counsel the patient about means of treating his erectile dysfunction postoperatively through pharmacological management or more mechanical means such as intracavernosal injections or a vacuum erection device.
Is there any way you can help the patient to improve the post-op erections by giving the medicines pre-op itself?
So I'm not aware of evidence preoperatively. I think PDE5 inhibitors can be tried preoperatively, but I don't know about the evidence surrounding preoperative medication.
Yeah, it's an old practice. People used to give PDE5 inhibitors pre-op itself as a part of recruiting as much of cavernosal tissues to maintain the erection. Coming to the urinary incontinence, what you will advise in the pre-op period to gain his pelvic muscle tone?
So I'll advise the patient that he needs to carry out pelvic floor muscle training preoperatively, and ideally I would like to have this supervised by a pelvic floor physiotherapist, and also that he will need to carry these out in the postoperative period too.
Okay. And what is your immediate post-op plan? Patient had radical prostatectomy. You're not performing lymph node clearance. What will be your plan for discharge? When you will place a drain or not?
The decision on whether to place a drain will depend upon the estimated blood loss during the operation. If it is more than 500 mils, then I will place a pelvic drain. I'll ensure the patient is catheterized and that the catheter should be removed no earlier than 2 weeks postoperatively. I'll ensure that the patient has postoperative blood tests measured the day after the operation, and that postoperatively they can eat and drink, they're encouraged to mobilize, and that they undergo standard VT prophylaxis with TEDs and a 28-day course of 28 days of extended prophylaxis with enoxaparin.
What is the dose of enoxaparin you'll be giving?
I'll give a dose of 40 milligrams once a day. And in terms of the discharge and follow-up, I'll ensure that the patient has his first follow-up appointment at 6 weeks following surgery with a PSA to be taken no earlier than then.
And enoxaparin you can teach the patient for self-injection so that they can do themselves when they are in home.
Yeah.
Is there any role of enhanced recovery protocol in radical prostatectomy?
There's no enhanced protocol as far as I'm aware. However, I would encourage the patients to mobilize on day one, and to have a normal diet on day one, as well as to ensure that he has a regular analgesia prescribed, along with antiemetics to be taken as and when required.
Is there any role for neoadjuvant treatment prior to radical prostatectomy?
There is no evidence which has demonstrated the efficacy of this. There has been studies looking at the use of androgen deprivation therapy, hormone therapy, but whilst this was shown to have downgraded the tumor, reduced the rate of positive margins, and to reduce it. So this did not demonstrate any overall improvement in terms of cancer-specific and overall survival.
Okay, that's a good answer. Okay, if the patient wishes for radiotherapy, I know you have a joint clinic with a clinical oncologist next door. Some days, if they are not there, how can you explain them to them?
So I'll explain to them that they would be having regular visits to the oncology centre to undergo the radiotherapy. I'll explain that there are two, according to the NICE guidelines, there are two means of delivering radiotherapy, either hyperfractionated, delivered over 20 fractions, or conventional radiotherapy delivered over 37 fractions, 74 grays. I will explain that about the potential complications of radiotherapy, including erectile dysfunction, proctitis, hematuria, and radiation cystitis, urinary incontinence, and the less than 3% chance of developing a secondary malignancy from the radiotherapy. I'll explain that the follow-up required will be in the form of PSA surveillance, and that there may be need for additional treatment if there is biochemical recurrence following radiotherapy.
Yeah, this hypofractionated regimen is as per the CHIP trial, CHIP. What is the role of adjuvant treatment in radiotherapy?
So adjuvant treatment is in the form of androgen deprivation therapy, and the evidence in the NICE guidelines, it's recommended for either before, during, or after radiotherapy for 6 months for patients with intermediate risk disease, and for patients with high risk localized or locally advanced disease, it should be continued for up to 3 years. The evidence for this comes from an RCT by Boller, looking at radiotherapy alone or combined with androgen deprivation therapy for up to 3 years. And this found a significant improvement in disease-free survival at 74% compared to 40% in the control arm, and a non-significant improvement with regards to overall survival with 78 compared to 62%.
And this BOLA trial is belongs to EORTC trial, even though it's commonly known as BOLA trial.
Yeah.
Okay. What is the role of brachytherapy? How will you select a patient?
So brachytherapy should be offered to patients undergoing radiotherapy. I think according to the NICE guidelines, again, it's for high risk or locally advanced disease. It is so it should not be given alone according to the guidelines. It consists of 2 stages: a planning stage with a truss and template, peritoneal template, and then the treatment stage is implantation of 60 to 150 seeds of either 125 iodine or iridium, and these deliver a total dose of 150 grays. It can be considered in patients with a good performance status. Yeah.
Okay. What is the difference between low dose and high dose?
Low dose brachytherapy. Sorry, I don't know.
Yeah, low dose is the one where there is seeds are implanted permanently. As you said, it's mainly like iodine 125 and also palladium 103. while the iridium 192, which you said is high dose one, which is temporarily implanted by plastic catheters, and the radiation dose is delivered within few minutes. The side effects will resolve over weeks in high dose, but in low dose, acute side effects will resolve, takes months to resolve, and it's slow. And in case of low dose, since it's going to be a very long standing slow radiation, we need to protect the patient and the carers. For example, if a patient wishes to have sexual intercourse with the partner, he is to use condom, and he can't be very close to young children or pregnant mothers, etc.
Yeah.
If a patient has radiotherapy and then the PSA is falsely raising, what do you know about this phenomenon?
So this is referred to as the PSA Bounce, and this is a benign rise in the PSA after an initial nadir is reached. It typically occurs within the first 9 months. It can take up to a year to resolve, and it should typically go no higher than 1.5 nanograms per mil.
Okay. You are planning your patient radical prostatectomy, everything goes fine. Patient develops urinary incontinence, but slowly got subsided over 3 months' time. Erectile dysfunction is there, but is nicely supplemented with use of PDE5 inhibitors, and he is comfortable with that. His specimen showed Gleason 4+4 occupying almost the areas what we saw in the MRI. No positive surgical margins, and the capsule is not involved, and all other things were free. Lymph node not dissected and not needed also. What will be your long-term plan in this patient's follow-up?
So in terms of the long-term plan, the plan will be to measure the PSA on a 6-monthly basis for the first 2 years, and then annually thereafter. These are according to the NICE guidelines.
Okay. And any role for adjuvant radiotherapy post radical prostatectomy?
There is no role for adjuvant radiotherapy, and the evidence for this comes from the Radicals trial, which randomized patients to either routine radiotherapy following Radicals prostatectomy or salvage radiotherapy following biochemical recurrence. And this found no difference in terms of overall, in terms of disease-free and overall survival between the two groups.
When will you say the patient got biochemical failure post radical prostatectomy?
So I'll define this when there are at least 2 PSA readings which are greater than 0.2.
Okay. So what will you do if the PSA is raising?
So I will request a PSMA PET-CT scan to look for any evidence of activity, specifically within the prostate bed, but also the rest of the body. And if this is positive, then I will discuss him at the local MDT.
Okay. We are completing the scenario. This scenario can come in slightly different formats, and we are just trying to cover everything in one umbrella. But nearer the exam, we will do specific 10 minutes individual scenarios so that you can use how this umbrella knowledge can be used for individual scenarios.
Okay.
We will just slightly divert and discuss the high risk prostate cancer.
Yeah.
You are on call, and you are asked by a medical team to review a patient. Patient presented with paraplegia. Unfortunately, his routine blood test, what the medical team sent, showed PSA in 1200. What will you do?
So I'll go and assess this patient myself, and probably because it's a urological emergency, and I'm concerned that whilst he has a likely diagnosis of prostate cancer with a paraplegia, he could also have signs of cold compression. So I'll go and see the patient myself in the ward. I'll ensure that he's hemodynamically stable. I'll take a focused history asking him more in depth about his symptoms, asking also about any LUTs, symptoms of advanced disease. I'll ask his age as well, and assess his general comorbidities and medical fitness, and a kind of about a family history of prostate cancer. And then I will examine him. I'll note his ethnic background. I'll offer a male chaperone. I'll examine the abdomen, looking to elicit any suprapubic or loin tenderness or masses. I'll examine the external genitalia, looking for any external abnormalities. And then I'll perform digital rectal examination to assess the prostate size and whether there's any irregularity or nodularity. And I'll also assess the anal sphincter tone and saddle sensation, and I'll perform peripheral neurological examination of the lower limbs. And then depending on my findings, I'll then go on to arrange further investigations.
Okay. His main problem is paraplegia. That's the main thing. Otherwise, he's quite fit gentleman. It seems to be quite very rapid onset paraplegia. Examination wise, it showed normal abdominal finding, external genitalia normal. Digital examination showed nodular prostate, easy T3 if not T4, measuring around 60 cc. As I said, PSA is 1300. What are you going to do?
And can I ask how old this man is as well?
He's otherwise quite fit. He's 68.
68. I will arrange him to have urgent investigations. I'll arrange for him to have an urgent MRI scan of the lumbosacral spine, and I'll go down and discuss this with the radiologist, happen on the day. I'll also arrange for him to have a bone scan, but I will commence this patient on upfront androgen deprivation therapy. In terms of the choice, first of all, in terms of the choice, I will, if there is probable spinal cord involvement, then I will arrange him to have an injection of, I'll arrange him to have a 28-day course of bioclitamide at a dose of 50 milligrams once a day, and 2 weeks into this to have an LHRH analog injection with a dose lasting for 1 month.
So what is the dose of steroids?
I'll also arrange him to have intravenous steroid injections, dexamethasone. I don't know the exact dose at this moment in time, though.
Okay, the loading dose of dexamethasone 16 milligrams, and then followed by short course of 16 milligram dexamethasone daily till the treatment is finally planned, and we can plan for the hormone treatment. So what is your hormone choice injection?
In my practice, I commonly prescribe a glycerolin, which would be at a dose if it's for a 1 monthly, if the duration is 1 month, and the dose is 3.75 milligrams. But if it's on a 3 monthly basis, then this dose would be, I think 10.25 milligrams.
So what LHRH antagonist you are aware of?
So I'm also aware of Degrelix, which is given on a monthly basis, and this is given dose. Initial dose is, I think, 160 milligrams, and the maintenance dose is 80 milligrams.
So why are you not considering LHRH antagonist for this patient?
I think it's just more in terms of familiarity with what I use in my practice, and availability on the formulary, but I don't know in terms of specific evidence.
I think LHRH antagonist Degarelix is the better choice. The loading dose is 240 milligrams followed by 80 milligrams monthly. But after 1 or 2 months, once the patient is stable, GP can convert them to LHRH agonist, whether goserelin as you said, or injection Zoladex. There is a new oral LHRH antagonist available by name Rigolix, which is FDA approved. It will take another maybe 6 months or 1 year to cross the Atlantic and reach UK. What is the role of giving anti-androgens in the initial period of goserelin?
This would be to prevent the tumour flare, which is due to the initial surge in LH and FSH, which is caused by giving an LHR antagonist, and the consequences of this are that it can cause acute urinary retention, ureteric obstruction, bone pain, spinal cord compression, or a hypercoagulable state which can cause cardiovascular complications.
Okay, so how long you're going to give bicalutamide? What dose?
I'll give a dose of 50 milligrams once a day for 28 days, and the goserelin dose is to be administered 2 weeks into this course.
How will you explain the side effects of androgen deprivation treatment to the patient?
I'll explain to the patient that this is a form of chemical castration, and that the side effects include fatigue, weight gain. They could include bone weakening, may experience cognitive and mood changes and hot flushes, gynecomastia, and also a slightly increased risk of cardiovascular complications.
There is also risk for mental health problems in long run. You've done some staging, more of like a completion of investigations. So what investigations you wish to order? The MRI spine showed spinal cord compression, which is acutely treated by the medical team. So what other investigations?
I'll also request a bone scan, so bone scan and also a CT scan of the thorax, abdomen, and pelvis with contrast.
Okay. His bone scan showed presence of not widespread, at least 3 to 4 areas of mets, 2 areas in the ribs and left forearm. So will this make any change in your treatment?
So this patient now has, he's got metastatic prostate cancer. I'll discuss him at the NDT. Given his age and relatively good performance status, I will discuss him with my oncology colleagues to see whether he can be offered upfront chemotherapy in the form of docetaxel.
So is there any study to support this?
This is from the Stampede trial, which demonstrated that upfront chemotherapy did improve disease-free survival by prolonged it by 1 year.
Okay. You can also quote charted trial. That's also equally good.
Yeah.
Okay. Now, in this acute situation, say for example, you don't have LHRH antagonist like non-availability of docetaxel, and you don't want to give LHRH injections and create a tumor flare. What other options you have?
Other options include enzalutamide, which is another anti-androgen drug, and abiraterone, which is a irreversible inhibitor of androgen biosynthesis. Those are recommended in NICE guidelines for patients who have no or mild symptoms and who've got a good Karnofsky performance status.
Any other surgical options available?
Surgical options.
Yeah.
I'm not aware of any evidence that prostatectomy in this scenario would improve overall survival or disease-free survival.
Bilateral orchiectomy?
Oh, yes, sorry.
So how will you perform?
So I'll ensure that the patient's appropriately prepared, consented, and anaesthetized. I'll place him in the supine position. I'll ensure that the WHO checklist has been done and that they have the appropriate BT prophylaxis. I'll ensure the area is prepped and draped. I'll make a midline scrotal incision, entering each scrotal cavity one at a time. I'll deliver the testes to the wound. I'll bivalve the testes, and I'll remove all of the seminiferous tubules that are present. I will eliminate any dead space within the cavity. I'll close the tunica albuginea using 3O vincal sutures. I'll perform the same procedure on the contralateral side, and I will close the dartos muscle and the skin with dissolvable sutures. I'll ensure that the patient has scrotal support and local anesthetic administered to this wound.
Okay, so it is bilateral subcapsular orchiectomy.
Yeah.
Very good. We will stop with this. We have purposefully omitted at least one small scenario on castrate-resistant prostate cancer, but that will literally stretch this discussion into a different end. I don't want too many fonts to be discussed in one single discussion. Overall, I'm very happy with the way the discussion went. I can clearly see the improvement in your pace and the knowledge backed up, even compared to the yesterday's scenario. Maybe yesterday you had a long steady day and also you are waiting for an on-call, but there is a good difference. So this good slow pace with a very calm knowledge-filled answers backed up with as much of evidences if possible. If you don't know the numbers, that's not a problem. If you bring the evidences, even if the examiner is expecting some numbers in that evidence, it doesn't matter. They don't really pick on that. For example, for docetaxel with ADT in a newly diagnosed metastatic carcinoma prostate, in charted trial, HR is 0.72, while in Stampede trial, HR is 0.78. If you say this, they're all good. But if you just mention at least the trial names, you will move on. And end of the day, there is a good possibility you may end up almost the same mark, and we wish to get 8 as much as possible. Any questions from your side?
No, nothing specifically going through what I've written down on my paper. With regards to degarelix compared to LHRH agonists, is that mentioned in the EAU guidelines or?
I think so. It's mainly because if the patient has got already spinal cord obstruction, even though you give bicalutamide, but that's only for tumor flare. If you are giving an LHRH agonist, there is a possibility of flare-up of symptoms. So the edema will be there, and especially if there are bilateral lymph nodes, it can cause ureteric obstruction.
Okay,
so ideal exam answer is degarelix. At least in SWBH, we have started using degarelix for patients who has some propensity to get into a side effect like ureteric obstruction or spinal cord obstruction, etc.
Okay, because I suppose even if you give the anti-androgens, the tumour flare is still possible.
Still possible.
Even if you give bicalutamide. So degarelix in this situation is better advised.
Yeah, it's definitely the correct answer for the exam, and in practice also, if available, it's the better choice. The only disadvantage with degarelix is none of the GP surgeries are happy to follow it up the 80 milligram monthly injection, and it's also costly. But once you give the first injection, once the patient is stable, once the obstruction is de-obstructed, whether it's spinal cord or ureteric, whatever the obstruction, then you can change it to injection Zoladex or whatever equivalent. And the dose is 240 milligram. The subsequent doses are 80 milligrams.
Yes.
Very good. Kumar, any inputs from your side?
I know Mr. Shrikant, I think you presented very well. He's covered good speed and knowledge is also there. I just want to correct him on brachytherapy. Piyush, I think when he asked how you select the patient, you will need to say IPSS less than 12, if I remember this correctly. It's IPSS 12 or less.
Yeah.
Qmax of 15 or more. Prostate volume, I'm not very sure about the prostate volume. I think it was
50 cc, I think, or previous T1.
Just have a check on that. And it's not for high risk. I think you mentioned high risk. It's for low and intermediate risk. It's definitely not for high risk.
Okay.
Yeah.
So
IPSS
it's not for.
Yes, IPSS less than 12 maximum flow rate less than 15, PSA level
No
less
more
than 10, and ISUP grade 1 with less than 50% course involved of the cancer.
Yeah.
And just one point I would like to add, that when you're describing a surgery, what my consultants taught me was that just use the word that in an adequately consented and prepped patient. I'll start with the whole checklist, and then you can jump in straight to the surgery. That saves you some time to fetch more marks by giving more information.
Yeah.
So that will save some time.
Good. Thank you, Kumar. Thank
Yeah.
you, Piyush, and
Thank you, Kumar.
we'll try to meet you in next 24 hours in the next session on andrology as per your choice, and
Okay.
we'll take it from there.
Thank you, Mr. Dhanasekaran.
Good. Have a nice weekend, both of you.
Thank you. You too.